Hi, I'm Mike Taigman. I'm the improvement guide with First Watch and also associate professor at the University of California, San Francisco's master's degree program in healthcare administration and interprofessional leadership, along with an adjunct professor at the University of Maryland, Baltimore County's master's degree program in emergency health services management. And I'm here to talk to you today about benchmarking in EMS. There are so many myths and misunderstandings around benchmark in the world of emergency medical services. It can make you pretty crazy. Most people, when they hear about it, they get excited. You know, we should do some benchmarking. You hear those phrases all the time. We've got a new electronic medical record system. We should do some benchmarking, or we're now participating in the NEMSQA quality management data set. Let's do some benchmarking. And everybody gets excited about it without having really any concept about what it actually means. And in the EMS world, historically, benchmarking is thought of as comparison benchmarking, where a number of organizations will get together and try to measure the same thing the same way and see who's better and see who's not better. And that produces nothing other than some people feeling like they were better and some people feeling like they weren't so good. I remember years ago when I was a full-time consultant, I was working with a group of high-performance emergency medical systems, and they were just really determined to do a benchmarking process that was a comparison-based benchmarking process, and they asked me to do it, and I tried really hard to talk them out of it, but they, finally the head of the group said, "Hey, look, we pay you to help us. This is what we want you to do, so we want you to do it." So they had 25 different measures that they wanted to benchmark among their 14 organizations. When it actually got down to the reality of looking at the data, it turns out they couldn't all come up with the same measures on the same things the same way. And most of them couldn't participate. So at the end of the day, we had one measure that 4 organizations were able to participate in. And here are those data from back at that point in time. And this was scene times for life-threatening trauma cases. And you can see here that in Charlotte, they were averaging a little better than 15 minutes on scene with major trauma cases. In Reno, Nevada, they were right about 15 minutes on scene with major trauma cases. In Tulsa, they started off right about 15 minutes with major trauma cases. And in Oklahoma City, they were about 14 and a half minutes on major trauma cases. So it's like, okay, so they spent a lot of money. They spent $30,000, and they spent that $30,000 on me, which was embarrassing, to end up being able to say, yeah, we're all about the same. It doesn't provide anything that is useful. You'll notice that there were some dips here in the Tulsa and the Oklahoma City trauma times, and that happened because at that point in time, the medical director in the system said, well, these numbers don't look good, and we shouldn't hold our folks responsible for times where the patient's trapped and it requires extrication, or there's an assailant on the scene, and we have to stage a ways away ahead of time. So they didn't actually change their performance at all. They just changed the definition for what's included and cut out everything where there was extrication or an assailant on scene. Not that patients' outcome would be affected by that difference at all. And most of the benchmarking systems and processes I've seen in EMS use this kind of comparative system where somebody feels good, somebody feels bad, and nothing changes. In the rest of the improvement science world, and the rest of the healthcare world outside of EMS, benchmarking is a strategy for performance improvement. It is a focus where an organization wants to improve a process, and they go look at an organization or another system that does something really well in order to extract benefit and ideas from them about what might improve. So one of my favorite examples of this is Charlotte, North Carolina. Joe Penner and his team up there. One of the they wanted to improve a couple of their processes. So rather than trying to look to some data set where everybody measured the same thing, they said, who's the best in the world about frontline team orientation? They really wanted to improve the collaboration and running of their frontline teams. And what they did is that through their research, they found that there was a Boeing engine plant that had won a Malcolm Baldrige Award, all focused around their incredible teamwork for their engine assembly plant. So the leadership team from Medic in Charlotte headed up and spent a couple of days with folks building engines at a Boeing plant, and extracted ideas and information that they came back, applied to their paramedic systems and processes, and used those to make measurable improvements. Another favorite example, Sarasota Fire Department wanted to improve their customer satisfaction rating. They wanted to improve their relationship with the people they took care of. And rather than trying to do some comparison on customer satisfaction or whatever with other fire departments, they said, who is really good at customer satisfaction? And they did some research and found out that the Ritz-Carlton Hotel in Naples, California is one of the world's best at customer satisfaction. So they contacted the Ritz-Carlton and said, hey, can we come learn from you about your ideas and your strategies? And Ritz-Carlton thought paramedics and firefighters were cool, and they said, sure, come on in. That's one of the nice things about being in EMS, is that other people think we're cool. So they'll invite us into their organizations. And the leadership team went down, spent a week at the Ritz-Carlton, actually went through their new employee orientation program to learn how the Ritz-Carlton trains their employees at really taking care of their guests as in an extraordinary and refined way. And they brought that back to the fire department and dramatically improved how their customers felt about their interactions with the EMTs, paramedics, and firefighters from the fire department. So those are some of the ways that you can do that from that perspective. Probably the only real effective large-scale benchmarking system that I've seen in our American EMS world, at least, has to do with the cardiac arrest resuscitation program, the Resuscitation Academy, that is put on by the folks in Seattle, part of Seattle Medic One, in partnership with Seattle Fire Department. They have got an extraordinary program where there's a whole team of physician researchers there, with Dr. Sears and Mickey Eisenberg and Michael Kopus and Richard Cummings and that group that have been really focusing on learning about how to resuscitate people for 35, 40 years. They've been doing that full time. And they will bring people together basically for free for the cost of your travel, and will share everything they've learned with you and give you strategies that you can take home and use it to make improvements in your system. And I know that folks in Ventura County, California, and Santa Barbara, California, in Charlotte, North Carolina, and Tulsa, Oklahoma, and Oklahoma City, and a number of places across the country have gone, learned, brought information back, implemented it in their system, and saved more lives as a result. So that's the kind of thing you're hoping to do. Starting by figuring out what it is you're trying to improve. What are you trying to do with your data? And if you're trying to persuade someone to take action, one of my favorite ways to learn is to go take a look at Florence Nightingale, who's pictured here in this slide. Most of you think of Florence Nightingale as like the first nurse that ever existed. And she did really kind of found the profession of nursing. But what she actually was a healthcare statistician, and used data to make improvements, which is kind of what benchmarking is all about. The project she was working on had to do with the death of soldiers during the Crimea War in the mid 1800s that the Brits were involved in. And this chart here is a star chart. It is by month. It starts with April of 1884, May, June, July, August, September, and goes around each slice by months here. And the folks in the red here in the middle are people that died from the wounds of war. They were shot or got hit with shrapnel. The other folks here in this kind of brown section here were folks that died from other causes, like being driven over by um, a wagon or falling off a cliff or something like that. And folks in the outer gray here, this biggest section of deaths, were people that died as a result of sanitation issues. So poor food hygiene, poor waste management and waste disposal, poor management of wounds and sepsis and related kinds of things like that, which is the biggest cause. So she used this chart to convince the British government to make significant investment, millions of pounds of investment in improving the hygiene and sanitation for soldiers. And this continuation here, this is March, this is April the next year, you can see the dramatic decrease in the death of soldiers as a result of hygiene issues. To summarize, the primary benefit of benchmarking is identifying an organization or a group that is extraordinarily good at whatever it is you're trying to improve, going to study from them, analyzing what they do well, and bringing those ideas back and testing them in your own organization using small cycle tests of change, the PDSA cycle that we have discussed in our quality improvement video as part of this series. Thank you very much.